Now I would like to invite Dr. Moses Kirubai Raj to moderate the session on providing healthcare for migrant populations by Dr. Pavithra Mohan.
Happy to introduce the speaker for this session, Dr. Pavithra Mohan. He's the director of Arjiva Bureau and co-founder of Basic Healthcare Services, Rajasthan. He obtained his master's in public health from University of North Carolina after his MD pediatrics from Safdarjung Hospital in Delhi. His work among marginalized is recognized, and he was awarded the Asoga Fellowship in 2017 for social entrepreneurship. He's also a fellow of National Neonatology Forum and a member of WHO advisory groups on newborn resuscitation and vitamin A supplementation. He has published numerous research papers and articles in Indian and international journals. We are looking forward to hear from you.
Thanks. And thanks to CMC and to Anand for inviting me here. When we think of India, and if we generally ask anyone in this room that what is the main occupation of people, how do people survive, how do they live, where do they earn their money from, the general answer would be probably farming, right? But that's not true. I mean, it's a big myth. And over the years, it's becoming increasingly clear that most people in rural India are not able to sustain themselves on farming alone. Either people don't have enough land, or they have, or it is rain-fed and extremely erratic. And in South Rajasthan, what we have been seeing is that what they grow in the farms, if they have a small piece of land, it's usually less than an acre for most tribals in the region. And that is sufficient only for about 3 months in a year for the family, right? You get supplemented for wheat by the public distribution system a bit, but for the remaining 9 months, you're pretty much on your own for food as well as for every other expense. So what do people do? They migrate to cities, right? And this is the migration that I would be talking of, because when we often start talking about migration, everybody says, oh, but I am also a migrant. But that's a migration by choice for improving your quality of life. It's not a distress migration. It's not to just survive and to, put food on your table for yourself and for your family. So it's those migrants that I'll be talking of. And sharing some of the experiences and insights that you gathered working, providing healthcare to communities which are from where a large people migrate to cities like Ahmedabad, Mumbai, Bangalore, Chennai, you name it. And, you're surprised that how could somebody who's never been to a city headquarters goes and works in Chennai with a different language and an alien. And I'll share some of those thoughts earlier. I just wanted to share this picture because this was a picture of the migrants who were returning from the cities in Ahmedabad. They had walked 250, 300 kilometers. You see, it's a barren, there's nobody else except for a few people here because it was peak times of COVID pandemic. And they walked after being hit by lathis on the way. And they just come, and if you look, there is a despondency on their face. They came and just sat outside a clinic and for some rest and confirmation that they are fine. I'll start with a few stories only to explain the context of what it means, and I think another myth is that either you are a city dweller or you are a village dweller, right? But many of these people are, moving between the cities, and their work is in cities, but their life, social life is in the villages. They themselves are many times in the cities, but the families and the elders and the wives and the animals, they are all and their land. So their heart is in the city, in the villages, but they have to force themselves to go and work in the cities. And that is something that is important when we talk of providing healthcare to the migrant communities. So this was an 18-year-old boy who came to our clinic. His father had brought him because he had been coughing blood for some days. He was working in Ahmedabad when he started becoming ill. He started coughing, but did not want to share it with anyone because he said he would have to go back, but kept waiting till he started coughing blood and was not able to do his daily work. In general, he was living alone since the age of 16 years because the school that he was working in was not worth its name. They were not teaching anything, and he felt that the master was scolding him, and therefore he went with his friends to Ahmedabad, started working at a construction site. And he moved back to the village because he was unfamiliar with the city there. Though, it is also paradoxical that Ahmedabad, which has some of the finest health facilities in the world, a person has to come back to the village to get treated, and you keep delaying because those hospitals are not for him. They are not for the migrant. It's not a city for the migrants. It's for using their labor, but not to provide them care. So that's what happens, that migrants would often come back from where they are, even if there is a bad health system waiting for them back in home in the villages. So he boarded the bus and he finished his money. He weighed 35 kg. There was a BMI of 15, and he was short of breath. He was confirmed to have tuberculosis. We started him on ATT food. He started gaining weight in about a month's time. He was better. He was feeling better. He had gained some weight. But he did not report for the scheduled appointment a month later. So when we phoned him up, he said that he has gone back to Ahmedabad because he was feeling better and his money, whatever savings there was, had finished. So he needed to go back to city to start working. So we went back. Then our health worker pleaded with him to come back or to connect to a dot center in Ahmedabad city. So he chose to come back. He listened to us. Some of them don't. So we gave him then a medication for a longer period of time and said that now you go and work for 2 months, but then do come back after 2 months. So he came back, he finished his work, but we tried to connect him to a skill training program that our partner organization Ajivika runs for enhancing skills of migrant workers. But at that time, he was not very keen to go away for a month or so to learn a new trade and start a new trade. So he went back to work after having completed his treatment. So with this kind of a story, I'll just also trying to understand that what really affects the health of labor migrant. Why should a person who's gone to work, he's basically escaping hunger. So why is it then he's at he and the families at an even higher risk of illnesses and ill health? So we had been doing a large number of, working with labor migrants for various reasons in one project to look at the tuberculosis, and in other to provide health services. And what we found across Ahmedabad, Surat, Mumbai, that most migrant workers were malnourished. They were working in construction, so they're lifting, can you imagine, like 100 kgs of weight on their heads, and their body mass indexes were like 15, 16, 17. So, doing heavy work with such malnutrition, and this is across. But as you see that there is now a changing trend in certain industries where both the nature of work as well as slightly higher income also is predisposing them to obesity. So you see that in Surat, for example, the power loom workers who have their own mess there, they also live in bad conditions, but the food they eat is unhealthy and therefore it's leading to obesity. So it's either malnutrition or obesity, but a large proportion of the tribal migrant workers from South Rajasthan are malnourished, as you see among the construction workers in Ahmedabad, which are amongst at the lowest end of the spectrum. So it's not only they who are malnourished and who don't get food, it's their families as well, right? This is about the women construction workers or their wives of the construction workers in Ahmedabad in a study conducted by a PhD student colleague from Washington University, where they found that almost 50% of women workers or wives of construction workers in Ahmedabad were also malnourished, right? They had a BMI of less than 18.5. And similarly, about 50% of the children were underweight and 22% were wasted. These are children at the construction sites in Ahmedabad. Okay? And when we looked at the other end from where people come, so generally in migration, one terminology to understand is to source and destination. Source is where they migrate from, destination where they migrate. So that was a destination data. This is from the source. So why are people moving? Because there is very little food, right? I mean, if you look at this data, almost 14% people did not have any wheat at home that when we visited. So this is a published data where we looked at 500 households, looked at mothers of children who are less than 5 years of age, measured them, asked them what do they have, what did they eat in 24 hours. But we also looked at what was there in the household on that day, the spot food availability. And we found that 86% people had some wheat, and this is any wheat. I mean, even if it is 50 gram, we considered it as having something. So 14% did not have any grain of wheat on the day that we went. Pulses, only 43% families had any pulse. Even if it was like 20 grams of pulse, the average, we estimated the average. This was like, I think 20 or 30 grams was an average median amount of pulses. But even that was not available in 60% of households. And forget about, vegetables, fruits, eggs, and meat. Oil was not there in about 27%. And the median oil was actually around 30 ml. That's what the food was there at the household. So that is what leads them to be malnourished and then to migrate, but then they are also continuing to be malnourished and lifting heavy weights and doing fever. So this is the second story that I'd like to take you through briefly, only to understand that it's not only migrant. You don't have to look at, when you think of a migrant, you think of a man, right? But there is a whole family that is around them who also gets affected, either positively or negatively, depends on several factors. But in this case, this was a 20-year-old woman who came to the clinic unaccompanied. She came in the evening. She was extremely sick. She had dyspnea. She was dehydrated. And on examination, we found that, further inquiry, that her husband, who was a 22-year-old man, he had migrated to Mumbai and had been working in a restaurant. He would come home twice a year. And she had already had 2 children. When she started becoming unwell, the husband abandoned and, left. So she came to move with the parents. So she came to our clinic. We were just starting off. We were also, very new. We didn't know how to handle somebody who's sick. And when we discuss later at some other point, it's nurses who largely manage the clinics. And so the nurses called us up and we started the treatment. On testing, she was found to be HIV positive. And she had no documents, and therefore it was not easy to link her to any of the existing services. We continued to manage her for next few days. After a few weeks of our workers working with her intensively at home and in the clinic, we finally connected her to an ART, accompanied her to the ART in the city, and CD counts of 40. We got her documents made. We helped her. Ultimately, she got a job in a not-for-profit, and she's doing well. Her 2 children are studying in a school, etc. But only to understand that what are the complexities of working with the migrants and their families, right? I mean, there is no husband. The documents have been left behind. She's 2 children, and the nearest hospital where the treatment could be initiated is 100 kilometers away. And even if you start the treatment, to go back and collect medicines every month and then to forge a life ahead is something that that I just wanted to. So that's one part, right? I mean, the migrant, their families, and nutrition being an important reason why migrants' health would be affected. The second important reason is the occupation. The people who migrate, as I said, are distressed, and therefore they also work in the most hazardous industries, right? Where nobody else would work is where migrants would work, because they're in a distress. And this is a case of silicosis in Pindwada. I think Dr. Shah was yesterday asking that where is Sirohi, and Pindwada is a block in Sirohi district in South Rajasthan. It has a high proportion of tribal communities living there. Mount Abu is incidentally there. Some of you may know that. And all the temples in the country and in the world, they are carved in those regions, right? Initially, there was a small community of people who were not tribals who used to make those pillars and idols using a hammer and a chisel. But now that has been replaced by the kind of machines that you see here. Right? And the fine, because of the machines, you are able to do a fine carving, but that fine carving also comes at a cost of fine dust. And that fine dust, when you inhale, lodges in your lungs and have extremely high silica content. And that causes silicosis in people even with 1 year or 2 years of exposure. So it's not even 10 years or 15 years, that what we traditionally learn, that long time. Earlier, it used to be after 20-25 years, if at all, because it would be by hammer and there will be thicker dust. So there are very nice temples all over the world are being manufactured. The idols are done here. Now, of course, the industry is expanding in different places. So in 2016, we did a study in 11 panchayats of this block to see that, and we surveyed like 14,000 families and 8,000 workers. And we divided those workers, out of those 8,000 workers, between 15 to 48 years, those who had been working in a stone carving industry for at least 1 year, which we called as the exposed group, and those who had not been working in the silicosis industry. And we looked at the reported deaths among them. And as you see, the orange line is those who are non-exposed, and the blue line is the one that is exposed. And you see that there's a huge increase in mortality. These are just numbers, right? In between 15 to a significantly increased number of people who died between 15 to 48 in the exposed group, right? So this excessive mortality is clearly on account of the disease, right? If you I'd like to share a few things here, that the number of deaths are much higher among the 278 deaths versus 76. But if you look at the average age of deceased, the person who died was on an average 35 years of age, right? When all of us are peaking in our work and career, they are already finished their career and are dying. And their children are now entering. So now we are seeing children, 2 generations of people coming together, the father and the son, both having silicosis, or the father having died and the 2 brothers coming now. with silicosis, and when the father has died at 35. And the average age of the wife, the widow who's been left behind, is 34 years, right? And there are almost 724 children out only in 11. I'm only talking about 11 panchayats of one block in one district of one state of India, right? Almost 724 orphan children. You know? So we run a clinic which is very close to this block, and therefore a large number of people have started coming to us for treatment. There's no treatment, right? I mean, and it's an extremely, one of the most frustrating parts of our work is that there's no treatment. But they come looking for treatment, so we try to help them. In last 4 years, almost 773 patients with silicosis sought care. 98% were males, obviously, because they are the ones. But it is now, we started seeing it more in the family members as well, because a lot of that work is done at home. The median BMI is 16.4 years. The age is 32 years, which corroborates with what we're seeing there. And 99% are Adivasis. As I said, this was initially a work done by another community, but because it is so hazardous, now it is done entirely by tribals. And many as young as 18 years who have worked for 3-4 years come to us with silicosis. Many of them have coexistent tuberculosis, and several on home started giving home oxygen only as a palliative measure to help them at home. So that was the second risk that migrants face when they migrate. They work in hazardous industries. The third important I think risk is housing. So this is from a mess in Surat. There's a lot of power loom workers who come from Orissa. Incidentally, from one district of Orissa, a lot of people migrate to Surat for driving those power looms. Increasingly, the power looms are becoming mechanized, but still the numbers are pretty large, and they live in areas like this. So this is one room, one large hall, probably smaller than this. Probably somewhat narrower, but longer. And there are people who live here in shifts. So if they are working for 12 hours, some 30-40 people will live there. And then in the night shift, another set of people will replace them. And there's no light, no ventilation, single toilet. And but they do run a mess because they can't eat food. I mean, I'm sure they can't eat any other food. So they have their own mess, which is also filthy, but at least they get what they like to eat. So all these factors of housing, nutrition, occupation lead to a significantly high incidence of diseases like tuberculosis as well. Right? If you just, this was a work we did 5-6 years ago in Ahmedabad city, looking at trying to address the tuberculosis among the migrant population. So there were 2 tuberculosis units which were intervention where we worked, or what we called as evaluation, and 2 which were control. The blue one is the control. So toward the end of the intervention, if you see for past 3 years, the incidence of tuberculosis was similar in between intervention and control. But when we started kind of active case detection and finding out patients with tuberculosis, suddenly the numbers shot up, which means that almost 200 per 100,000 population of TB patients were hidden till then, because one was not able to reach them or they were not able to reach out. When we started actively case detecting, it doubled almost the incidence. So this is the kind of the burden that remains invisible and hidden there. In our own clinics in southern Rajasthan at source, we over the last 4.5 years, there are almost 2,300 patients with tuberculosis, the average age being 30 years. Again, kind of corroborating with the peak kind of working age, which leads to 95% are Adivasis. Median BMI is 15.2. Again, highlighting the correlation with nutrition. So some things that we have done, I'll share with you only as an examples of what are the possibilities and the complexities of delivering healthcare to these populations. One is we run a network of primary care clinics across 6 locations, serving about 100,000 populations across the district of Udaipur in different locations, and each of them provide us with a different epidemiology and an access to a different location. Like the one where there is a lot of silicosis, there's another one, the clinic which is shown here, has a lot of tuberculosis, and then there are some where there are more NCDs and etc. But the migrant-friendly features here being that they are located within high migration communities. In these communities, about 60 to 70% households, someone would have migrated for varying periods of time to a city. The providers are women, which helps because often the men are away and therefore women have to face the burden of the work. And if the providers are not women, then women and the children are less likely to be cared for, and they're more comfortable with. When it is a one-stop shop, so it helps women not to go around at multiple places to buy drugs or to get diagnostics, and which is just not possible. We partner to help people link with skilling and entitlements, right? I mean, The families that are left behind are helped to get the entitlements like PDS, and for skilling, like, things which are not dependent on heavy work. So many of our TB patients, then we refer them back to skilling to help them, reconnect with something that is lighter, and still they can, earn their livelihoods even after being treated. That's another thing. And I think at some other point that many of the TB patients, even after complete treatment, because their lungs have been damaged and they're malnourished, are not able to go back to the same degree of work. And if they go back, they have a relapse and the ability to manage occupational health issues. So this is one, core of services that we provide to high migrant communities, both to migrant themselves and their families. And since it is closer to where people live, more likely to be accessed. Then managing silicosis patients, as I said, it is a frustrating part of it, but we try to do the best that we can. There is very limited literature on how to really manage silicosis. There is, in textbooks, there is very little. Even in the published literature, there isn't much. So we kind of, by a bit of hit and trial, bit of what we learned from others, we manage them, including with home oxygen, because that's like a palliative measure towards the end of life. Assistance with social security to get reimbursements, claims, etc. And chest physiotherapy helps as well. You can see taking a rotahilar in a foot area. There is also a lot of advocacy we've been doing with state government for last several years, which did result in a silicosis policy of the state, becoming the first state to have a silicosis policy, but poorly done. A lot on reimbursement or on claims rather than on preventing silicosis. So nobody is going to tie the industries which are polluting, but still there is a policy that we kind of help people to get the reimbursements, which is up to 1 lakh rupees and 3 lakh rupees and 5 if you die. So there's a union of stone carving workers that our partner organization Ajivika Bureau has set up, which helps to, and it's a different story, and we'll, probably don't have enough time, but there is a union of which is called a Patthar Gadai Mazdoor Sangathan that works with the factories to improve situation or to get claims. We just tying up networking and partnering with National Institute of Occupational Health in Ahmedabad for research on silicosis. There are some interested groups there that are working on it. We also have been working with, in last few months, working with NTEP, National Tuberculosis Elimination Program, to integrate silicosis guidelines in the NTEP, because none exists. So in tuberculosis, there is some section on occupational health, but there are no guidelines on what to do in areas where there is high silicosis. We're exploring legal options to see how to, handle this industry, which is causing hundreds of deaths. And the guidelines that our, colleague and friend Dr. Ramni has put together for preventing, summarizing all the information that is there on silicosis and putting it together for something for practitioners and policymakers and program people to understand. So we put it together. We'll probably soon make it more open for others. Despite all this, it is expanding, and they have moved from this block to another block, where again the situation is roughly similar. We run daycare centers for migrant families and their communities, because if husbands are away, mothers have even less time to take care of the children, and with lack of food. So we run about 16 such centers in Udaipur, and about 13 of them in Ahmedabad city in construction sites. So the one on the left is in Ahmedabad, the right is in. So one of the very happy kind of moment for us when our partner organization, we've been thinking of it for a long time, but a dream come true, where a hostel has been set up for migrant workers in Ahmedabad city. So it's a clean space, it's well done, it's with dignity, there is good food. As you see, they're sitting together, and as compared to the picture that you saw earlier of a mess, this is like it has just started, and it is happily named Republic Hostel. I just wanted to show you this. This we found out during the COVID, when migrants started returning, that, in the first phase of migrant, when everybody was saying that migrants would bring back infection in the city, in the villages from the city. And we followed up 1,200 people who returned to our PHC area, and we found that none of them had COVID, even on the follow-up of 2 to 3 weeks. What it showed, what struck us was that these are people who were never assimilated in the city. If they were, they would have got infected, right? They're living in the factory sites, they're living with no interaction with people of the city, right? In the second wave, but once they were held up, though these were among people who ran away despite the lockdown. In the second wave, when they actually were released and they started coming, that's when they brought back infection. Because during those time, when there was messes and other things, aid and all of that, that's when they got infected. So it only talks of social distancing that kind of came to our minds, that migrants are in the city but are excluded from the city. So last two slides, is the time? Okay. So some insight, some summary of what we've been seeing and saying, that often migrants are considered as perpetrators. If you look at medical literature, they will always be seen as criminals who bring HIV to or to the who perpetrate, and they, or in the mainstream, they would be often seen as criminals or thieves or people who would make the city difficulty, while they are contributing usually to the, and they are not seen as victims but as perpetrators. And it is rampant amongst the medical fraternity that these people, that is, the tuberculosis came because even in places like Kerala, which are otherwise fairly progressive, even in terms of migrants, the health systems people say that tuberculosis and measles has come back because of. So I said that is your duty to then help them with services, not to, they are the ones who are contributing to the economy. So the other thing to remember is that migration affects the migrant, but also their families and communities. And we need to understand the impact on not only on the person, but also on the families. And there appear to be these key drivers. There would be others, and I'm still not touched issues like mental health and others, but poor nutrition, unhealthy living conditions, or housing and hazardous occupation. They are the, to our mind, appear to be three key drivers of ill health among this population. Which is compounded by absence of migrant-friendly healthcare services in the cities, and generally poor and unresponsive healthcare services in the villages. So that further compounds the situation of nutrition and occupation and housing. And therefore, I think there is a need to work on multiple fronts and in adaptive ways. There is no one way of addressing or providing healthcare and providing decent living and work for this population. Some of the agenda for advocacy that we set up both for ourselves, and I would encourage others to kind of think through it, that there is an extreme need for food systems at the source, right? I mean, there are, what in US would be called as food deserts in India. A lot of these places where food is usually scarce, those are the places where there's a lot of tuberculosis, a lot of malnutrition. And there needs to be, I think it is high time that there is a more sustained kind of food system approach to ensuring food availability in those areas. And similarly, entitlements at destination. So migrants often would not get, for example, a ration or food which they are entitled to in the villages at the destination. There needs to be absolutely critical to have safe housing for migrants. I mean, I think every city in the world has developed only when housing became more universally available, of basic quality and ventilation and food and sanitation. In our case, the enforcement of safety measures for stone carving industry is absolutely critical, and whichever way it can be done, we to follow up. In Rajasthan, I mean, people are talking about the right to health, and we did get a right to health, but there, of course, with all its shortcomings, but one of the major shortcomings that we could not negotiate with the government, and that's increasingly happening in a federal country where states say, no, I will only look after my people. Right? And who are your people are those who were born, and I don't know what criteria they use, but anybody who's coming from the other state is not part of. So right to health in Rajasthan also, so far our negotiations have not led to inclusion of migrants in the right to health. And there needs to be more migrant-friendly health services in destination and source, language closer, etc. And childcare is something that's, I think, absolutely critical, whether in the destination or at source, for children who are both at risk of nutrition, but also of various things, like in villages, children falling in the wells because they're unaccompanied, the mothers are away, or a brick falling on the head if at the destination. So things like that do require, I mean, it's absolutely, I think in any civilized society, not having childcare for children and children being left unaccompanied is not acceptable. Thank you very much.
Thank you very much, sir, for your interesting talk. I have a few questions for you. One of the questions is, how do migrants with chronic diseases manage their treatment, especially seasonal migrants who need to move about?
Manage. They will take occasional treatment, and only if, for example, in our clinics, if they have to move back, we provide them with longer duration of medicines. In cities, they would sometimes, if they have money and time, they would go to the nearest person and collect something. But in general, it's, they often don't, it's very difficult for them to adhere to the
So one question online is that how migrant families are affected and have poor health seeking behavior. I, as a medical student, have observed the tertiary hospital is just 2 kilometers away, but they have the same reason that we cannot give so much time. The healthcare is nearly at the doorway, but in vain. What really needs to be done?
I think one just needs to understand that better, because every context would be different. But I can tell you from our own context that, as I say, mothers just don't have time, right? I mean, when the husband is away, you get up at 4 o'clock, go to collect firewood, which takes 3 to 4 hours on many days. Then you come back, you have to look after the children, after your elderly parents, parents-in-law, whoever is living with them, animals, work in the farm, do the household work. So all of that leaves very little time for the women first. Secondly, they have also very limited autonomy when it comes to the decisions of spending money. If you have to go out and if you have to spend any money in, reaching there. And the third is unresponsive health systems. If the systems don't treat you shabbily, you progressively then avoid going there. Right? Now, what we have seen is that in our, in the clinics that we run, we try to provide more responsive services. They're affordable. They can be free if people don't have any money. So women do come, right? I mean, progressively, so we keep monitoring that as well, that how many out of total proportion of people that you receive. In general, it's always been above 50%, 60%. There now, when we started, of course, very few women would come. But now, even for antenatal care, there are women walking 6-7 kilometers also to just receive a routine antenatal care as well. So I think a lot of it is about responsive care, considering that everything else we can't change. But if we provide responsive care, and women-friendly care and a dignified care, people will come.
What is the role of contractors who employ these migrants? Are they under any obligation or law to give them certain care?
So, under law, the principal employer is still responsible. The problem is to even establish that who the principal employer is. There are a chain of contractors, subcontractors, and subcontractors who are often, some of them are actually their brothers and sisters only. They are the ones who went early, who survived this big bad world and now have made it to become a contractor. So he will get 10 more young boys to come and work. But to establish that who is the principal employer sometimes can get actually, they are responsible. The principal employer, even if they are contractual. But to establish even that nature of contractual relationship is sometimes not easy.
Regarding the silicosis part, are there any equipments to protect these workers from exposure, and can they be made mandatory?
So, the kind of dust that flows around, any mask, we have reviewed it extensively. And as I said, Dr. Ramani reviewed it again recently, that any mask, any regular mask, including the ones that we used during COVID, would not work at all. The industrial masks can work, but they are the ones where you can't even breathe. And they also would get clogged in 4 to 5 hours. So which means then they cost a lot of money. So if you have to change it 2-3 times in a day, and with with such, you can't even breathe. So it is impossible to. So the solution actually which lies with the industry is to change the technology. So there are machines which either sprinkle water or they suck the stone as it is produced. But they don't use it because one, it is more expensive, and and when you use these features, then it also becomes somewhat slower. So the industry needs to invest in it and take other measures. There are other kind of design issues, like if the airflow of the factory, where is it coming from, and things like that. So that it is a design problem, but ultimately it's a mindset problem. It doesn't matter if somebody gets silicosis, you'll get someone else. So it will reduce the profit for sure for the industry if you have to implement these measures, but they are not. It will not. If the temples or the pillars are not slightly less carved, it's not going to kill anyone, right?
So we have time for one more question. Regarding the national programs for people who are TB and HIV were on treatment, how do these migrants source their treatment or continue their care?
So in the program, there is a provision, right? There is a provision that the host, the TB unit or the dot center, can shift out the patient to the city unit and they can take over from there. But we've seen, at least in this corridor between Udaipur and Ahmedabad, it often doesn't work because, as for the reasons that I said, people are actually not even assimilating. many people that I ask in Ahmedabad that, have you ever been to any other place in Ahmedabad? They've never been to anywhere. They've just been in the factory, lived there, and then come back to Ahmedabad, take a bus. So going to the dot center and taking the medication or connecting to them often and unfamiliarity and all of that makes it more difficult. But theoretically, there is a program, and I'm sure in some states it might be working well also, because some states have a better TB program where.
Just one last question online. Are there any migrant communities in the country where they are doing well? Are these models good and replicable?
Ramni, you want to say something? Saying it doesn't work. Yeah.
Yeah.
With the migrant trying to plug it with the dots, it doesn't happen.
So what's successful, and we currently also still run it after 5-7 years. We don't invest much. It is now more or less self-sustaining. That we set up a dot center run by migrant workers or their family members within a high TB and high migrant community. That has been running for last 4-5 years, where they're able to then continue treatment. But in general, it's so there are models, and I don't think we have time enough to discuss a lot of it because it is a complex issue. But we can, maybe discuss online about some of things that have worked at certain levels. Kerala, as I said, is somewhat more progressive. They've started kind of building some housing for migrant workers, etc. But again.
I'd like to invite Dr. Moses to give the memento to Dr. Pavithra Mohan.